treatment option for sarcopenia and frailty among older diabetes. So what I will do it, basically I will speak on how to approach the sarcopenia, and something few slides for frailty, how we'll define it. And after that, some studies which has been done in Bhubaneswar, particularly in AIMS and SOM Hospital, and one study I have taken over is not published. And then treatment option, what are the treatment options available? So I'll be covering with introduction, defining sarcopenia, how will you define the sarcopenia, evaluation of the sarcopenia, epidemiology like prevalence, causes and risk factor, and the treatment. So as you know, the sarcopenia is a reduction in the muscle mass, that is muscles mass associated with, there is a decrease in muscle strength and the performance, and which is associated with increased morbidity, mortality due to physical disability, falls, fractures, and that all leads to increased mortality. So there are various criteria, but we'll be concentrating on the Asian criteria and the European criteria. So for that we have to measure the power, so hand grip strength by the jammers dynamometer, and which define that if you have a 26 gram less than 26 kg less than in male and 18 kg less than in women, and muscle mass which has been measured in DEXA, that is appendicular lean mass divided by height meter square, 7 in male and less than 5.5 kg per meter square. And if the gait speed is less than 0.8 meter per minute, then we will define as a sarcopenia. But sarcopenia, there is a different, like probable sarcopenia, and the severe sarcopenia that I will be discussing in the subsequent slides. So frailty defining was the first described by Freud and a colleague et al., and which defined as a clinical state in which there is an increase in an individual vulnerability for developing an increased dependency and or mortality when exposed to some sorts of stressor. And you can find at age more than 65, it is around 15%. As the age progresses, it's almost 1/4 of the older population, they suffer from frailty. And there is a cascade of functional decline in older adults from independence through to frailty and disability, which has been divided into 5 components. Number 1 is the weakness, which is by low grip strength, slowness, shrinkage, exhaustion, and low physical activity. And among that, the weight loss is usually the last of these 5 physical characteristics to manifest. And who is at risk of muscle atrophy, and how do we identify it? So for that, the diagnosis process of sarcopenia, you have to have the case, assess, confirm, and severity. So in the primary care setting, we have to screen with SRC5. That is, if it is more than 4, then screening that probably this patient having sarcopenia. Then for assessment, we can assess with DEXA or bioelectrical impedance. So we have to measure the muscle strength, that is hand grip, or physical performance by 6 meter gait speed. And if it is there, then probably we're dealing with possible sarcopenia. Then there is a primary center. We can have a lifestyle modification in diet and exercise. Then we can send to the hospital. Then from the hospital, then the process of confirmation, we have to do the muscle strength, physical performance. Then we'll do the muscle mass assessment by the DEXA or by electrical impedance, which has been shown in DEXA. If in male, it is less than 7, and female also in less than 7 kg per meter square. And in female, it is 5.4 in DEXA and 5.7 in BIF. Then in severity, we say sarcopenia if they have a low muscle mass plus either low muscle strength or low physical performance. If we have a 3 component, then it is a severe sarcopenia, and which is increased morbidity and mortality. So this is the ASEAN group of sarcopenia in 2019, which is I have described in the last slide, the assessment of the muscle mass by the DEXA. If DEXA is not available, we can go ahead with bioelectrical impedance with some sorts of limitation in that. And we can have a hand grip strength and 6-meter gait speed. So these are the various prevalence you can see from India. It is a cross-sectional study and taken the EWG SOP, that is the European guideline of sarcopenia, and they found in comparison to the control, the case having 44% of sarcopenia. And in study which has been published in 2023 September, and they have taken the SAN criteria of sarcopenia and they found 35%. In our study, which has been published in 2022 in endocrine and diabetes, we found in 45%. And these are the above 50 years old. And the recent study which has been going on in type 2 diabetes, more than 60 years, we found almost 45% of the patients are having sarcopenia. And it is not yet published. We are still analyzing our data. So coming to the causes of sarcopenia, sarcopenia can be divided into two categories, primary and secondary. So primary usually is the age related, and there are various factors like endocrine factors, and there are some predisposing factors, and you can have a nutrition and metabolic malnutrition, decreased protein intake. So that all leads to muscle mass, decreased muscle mass and the function. And what is the more important, the key pathogenesis is the mitochondrial dysfunction, and there will be production of ROS, and then all that leads to decreased protein synthesis, imbalance, and increased protein degradation, and all leads to decreased muscle mass, decreased muscle strength, quality, and physical activity, and we diagnose them as a sarcopenia. So by using a simple mnemonics, we can have 4D like drugs, the most important: statin, fibrates, steroid, and alcohol, and other res common like chloroquine, colchicine, antiretroviral drugs, and most importantly, what we get in day-to-day life is the type 2 diabetes, because the diabetes prevalences keep on increasing and it will increase, and other diseases like chronic liver disease, kidney disease, heart disease, and osteoporosis, which is the term is called the osteosarcopenia, and deficiency like poor dentition, where patient can't able to take food, vitamin D deficiency, and other anorexia, malabsorption can lead to sarcopenia. So coming to the molecular mechanism, there are 4 mechanisms which is operate. One is the age, which is called egrin musculoskeletal LRP4, which is responsible for the neuromuscular junction interactivity and the impulse propagation. If there is, that will be problem, then that can lead to sarcopenia. The second most is when the age progresses, there will be decrease in IGF-1, that will lead to PI3K, AKT, mTOR pathway will decrease, that leads to decreased protein synthesis. And there is like degradation of protein, autophagy, and UPS or malnutrition. When there will be activation of FOX, there will be increased proteolysis, or when there is a stellate cell dysfunction. So that also leads to production of the sarcopenia or initiation of the sarcopenia. Now coming to the treatment, there is basically 4 groups of treatment. Number 1 is a physical activity, and among them the most important is the resistance training, aerobics exercise, balance and flexibility training. And for prevention, you can have a nutrition like protein intake and branch chain amino acids like essential amino acids like valine, leucine, and isoleucine. Some extent vitamin D. The studies are not very vitamin D and calcium. They usually increase the muscle strength, but not the mass. And combination of the physical activity and nutrition, they do best. And some of the investigational drugs like myostatin inhibitors, all I will be discussed in the subsequent slide. And there are some herbal medicine also helpful for the treatment of the sarcopenia. So the treatment approach to frailty and sarcopenia, you can see this World WHO and International Conference on Sarcopenia and Frailty Research recommended that at least 150 minutes of moderate exercise per week, or 70 minutes of vigorous intensity aerobic activity should be done. In addition, this guideline recommends performing a muscle strengthening activity at least twice a week on non-consecutive day to maintain or increase muscle strength and endurance. And that should be done with a exercise specialized with specialists on delivering this exercise. It will be supervised first, then subsequently patient can do. And you can see the designing of resistance program, you have 4 stages, which is training frequency, exercise selection, exercise intensity, and volume and rest. You can see in the right side of the cartoon, training frequency, 2 sessions per week. Exercise selection, you can select the lower body or upper body, different parts. Exercise intensity, repetition, continuum based on a prescription, exercise volume, and rest period. All need to be concentrated. Now, coming to the treatment, you can see the all patient is the best practice guideline taken from the BMJ. The first is the resistance training, which I have explained, followed by protein intake, and which is, you can know this 0.8 grams per kg body is the normal protein recommendation for the normal individual or adult. But in sarcopenia, we can give 1.2 and up to, in some patient, we can give up to 1.62 grams per kg body weight, and adjunct aerobic exercise to maintain overall health. But resistance training is preferred option for managing sarcopenia. And the nutritional intervention which act in different site, in the myostatin inhibitors which act in AKT SMART pathway, so that will stimulate the AKT, and so it will increase the protein synthesis. Ursocholic acid, which stimulate the IGF-1, subsequently AKT, so that will muscle mass. Omega-3 fatty acid and hydroxymethyl butyrate, I will be discussing it. It acts on mTOR, so that will leads to muscle mass and strength. And polygonal, which act on the autophagy. Autophagy is a process where the unwanted cell has been removed. If you don't remove the unwanted cell, then stellate cell cannot help in neogenesis. So to have a neogenesis, you have to remove the diseased or damaged cell. So polygonal is act, and subsequently it provokes the autophagy. That's why there will be myogenesis, and muscle power will increase, or muscle mass will increase. So omega-3 fatty acid, the primary outcome, it is a randomized control trial, and which is the upper extremity muscle strength and lower extremity physical function. This is a 16 RCT showed that high dose 2.5 grams per day yield greatest improvement at both upper extremity muscle strength and lower extremity physical function. And it acts modulate the neuromuscular junction, increase the muscle protein synthesis, and decrease the muscle protein breakdown. And the mechanism of action is anti-catabolic effect on the muscle protein, anabolic effect on muscle protein, restoration of the insulin sensitivity, modulation of mitochondrial functioning and muscle fiber contractility properties, and neuroprotective and motor neuron excitability properties all may be modulated by omega-3 polyunsaturated fatty acids. Now coming to the leucine and hydroxybutyrate, hydroxymethyl butyrate, and which has been seen that this is a metabolites. HMB is a metabolites of oxidation of leucine, and around 5% of the ingested leucine is converted to HMB. And an open label randomized control trial in healthy older women concluded that if we give this, there is a promising result in strength, although it has no significant effect on short physical performance vector score. But its therapy in older adult is still not clear, so they have not recommended for the sarcopenic older patient to be given this medicine. Then coming to the investigational drugs like myostatin activin pathway, there are some monoclonal antibody LY2495655, and a monoclonal antibody that binds to and inhibits activin receptor in type 2B, there are some study, but these drugs are still considered investigational and further research is required. Now coming, which is the most important, is the exercise and the diet has got lot of beta analysis. I will be giving only one. And this is the 7 methods of treating sarcopenia, including resistance exercise, aerobic exercise, mixed exercise, nutrition. Resistance combined with nutrition and mixed exercise combined with nutrition, and electric stimulation combined with nutrition and their effect on physical function. This is 2,485 patients, and what they found in terms of improving muscle strength, resistance exercise has the most significant effect on improving the grip strength. Resistance exercise combined with nutrition lifting performance best in chair standing test. For muscle mass gain, resistance exercise increase appendicular skeletal muscle significantly, while resistance exercise combined with nutrition significantly increase fat-free mass. And resistance exercise combined with nutrition is best result we are seen in time up and go test. So in one line, resistance combined with nutritional intervention has the best effect on relieving the sarcopenia and can effectively improve muscle mass, strength, and functional performance. Now coming to the 1 or 2 slides about the diabetes and sarcopenia is the bidirectional. Hyperglycemia in elderly we consider is more than 65 and above or 60 above. And hyperglycemia leads to sarcopenia, dementia, and depression, and that leads to decreased ADL. And the characteristic of skeletal muscle in patients with type 2 diabetes, we have 3 different kinds of muscle fibers: the type 1, type 2A, and type 2B. Type 2B are less mitochondria, and type 1 and type 2A myofibril are having the more mitochondria, and they are having aerobic condition to generate the ATP. So these are more involved in type 2 diabetes. And in type 2 diabetes, there's a decreased insulin-induced glucose uptake into the skeletal muscle, and fewer capillaries, regardless of the myofibrils, are present, and decreased expression of PPR gamma and increased expression of propelfil factor 15 all leads to process of initiating the sarcopenia. And you can see there are various drugs which is used. We can see the association with improved physical performance in observational studies says probably bioguanides like metformin and thiazolidine, and some extent DPP-4 has some effect, and insulin has got some effect. Otherwise, there is no other drugs. Bioguanides also has some effect in improved physical performance in preclinical interventional studies. Improved physical performance in human intervention study also seen by the bioguanides. So in a single line, probably bioguanides has got some effect in that of the thiazolidine. Otherwise, SGLT2 inhibitor, they have an improved physical performance and preclinical intervention studies. So otherwise, none of the drugs has got effect in improving all the 3 parameters of the sarcopenia. And these are the various drugs, how they modulates the inflammatory and the glucose profile, and by doing that, they improve the muscle strength or the performance. And this is the slide when I was searching, I found the safe, inexpensive, easily available herbal medicine like curcumin, green tea, and ginkgo biloba and soya, that is reduce the stress, reduce inflammation, and increase the PI3K activity, which is the one of the most important pathway modulating the TOR. It increases the muscle strength. So by modulating all this, they can have a positive effect in physical performance, hand grip, knee extension, weight lifting capacity, mitochondrial density increase, muscle fatigue resistance, increase in mean fiber area. So that all can lead to decrease in sarcopenia. So the overview of current strategy in potential benefit and limitation in managing the sarcopenia: exercise intervention, protein ingestion like amino acid and vitamin D, therapeutic agents. If there is a deficient like testosterone in male, probably there is some effect. And then the potential benefit is there is an increased muscle mass and strength, high mobility, increased protein synthesis, increased muscle mass, strength. And what is the limitation? The patient usually don't adhere to the exercise, and sometimes the poor nutritional status, anabolic resistance, and there is no approved drugs for the treatment. And probably some drugs are there which are having some side effect, like myostatin inhibitors. They have some side effects which has been tried in the cancer cachexia and has been withdrawn from the market. So these are the the drawback for the management of the sarcopenia. So in takeaways, sarcopenia and diabetes are bidirectional in nature. Resistant exercise, nutrition, protein supplementation, and good glycemic control in case of type 2 diabetes in sarcopenia is the key to success. It is an evolving condition that is not addressed properly, if not addressed properly, can lead to morbidity and mortality. The diagnosis of the sarcopenia with various diagnosis criteria has been put forward for over last decade and included in ICD-10 for a few years back. And it is a evolving science, evolving disease, and lot of things may need. We have a normative data for our own, which has been there in Chandigarh. Sarcopenic SAR has done this. And there is a adequate screening facilities is there to diagnose in the primary setting and can be referred to tertiary care level for the adequate treatment. With this, I will stop my talk. Thank you for the patient hearing.
Thank you, Dr. Behera.